Hi, everyone. Welcome to Grand Rounds this week. Before the speaker introduction, I just wanted to make an introduction to this idea for a new series that we have. As you know, that most of our talks are driven by division or specialty specific topics, and the division chiefs and the divisions assign this or pick some speakers. With thought that with the emerging role of technology and innovation, which has always been obviously an important part of medicine, but particularly in the era in which we live now, it would be nice to have a recurring series that focuses specifically on technology innovation and its role in medicine. And so we wanted to kick that series off with someone who is that you'll hear more about, that's internationally known and a colleague of a lot of for a lot of us and a mentor for many of us, who runs our Gordon Center as the initial speaker for this series. So we're hoping this starts a yearly opportunity for us to really have a dedicated talk to technology and innovation in the medical space. So thank you very much, and I'll have Dr. Noy introduce the speaker.
Good afternoon, everyone. So Dr. Issenberg is a Michael Gordon Endowed Chair of Medical Education, is tenured professor of medicine here at the University of Miami. Dr. Gordon Issenberg received his medical degree from the University of Miami and carried out his residency at University of Alabama at Birmingham and the University of Miami-Jackson Health System. Dr. Issenberg has led an international consortium of clinicians, educators, and technical specialists that developed innovative training systems that are used at more than 2,400 institutions in greater than 60 countries. The longest standing example is Harvey, the cardiopulmonary patient simulator, originally developed by Michael Gordon in 1966 and is now in the 11th generation, training hundreds of thousands of learners each year. Dr. Issenberg has led several initiatives at the University of Miami, integrating the use of new technologies for learning and assessment of students and the faculty at all levels, and has been a key member of the development and implementation of the new Gen Med curriculum. Dr. Issenberg has authored or co-authored more than 200 publications and digital applications on the development, use, and evaluation of innovative training systems in health sciences and education. So please welcome today, Dr. Issenberg.
Good afternoon. Thank you for that introduction, Dr. Noy and Dr. Deshpande, and thank you, Dr. Weiss, for the opportunity to be the inaugural speaker on this new series on innovation in internal medicine education. The sub-theme is grounding simulation, the science of expertise, mastery learning, and patient safety. Having flashbacks, as I was a second-year medical student, we had our classes in this very auditorium. It's a little bit updated, but a lot of it's the same. In terms of disclosures, no personal disclosures, but the Gordon Center does have agreements with Laerdal Medical, a large simulation company, and the American Heart Association. And royalties received from those distribution agreements from some of the products that we distribute around the world are directed back to the Gordon Center to support ongoing research and development. The three main learning objectives today are define the core features of mastery learning, which is the really highest form of competency-based or proficiency-based learning, and how they support a shift from being judged on progressing based on your competence as opposed to a period of time. Recognizing medical error as a training problem, describe ways how mastery learning can serve as a direct patient safety strategy to reduce diagnostic and procedural failures. And it's appropriate, I think it was just coincident that we're right in the middle of Patient Safety Awareness Week. And so you'll hear some of the themes of how patient safety has inspired some of the work that we do in simulation. And then a continuous theme throughout the entire presentation will analyze the role of simulation and more recently extended reality and artificial intelligence as tools to help us operationalize deliberate practice for training. A little bit about what we do at the Gordon Center. Many of you know where we are. We're the first two floors of the Sofer Clinical Research Building. Our theme is saving lives through simulation. And so the tool that we use is simulation technology, but our goal is all for the intent of saving lives. And we do many things, all grounded through or unified through collaboration, multidisciplinary training. Each year we train more than 20,000 learners using simulation. The largest population of those are pre-hospital providers who serve the communities throughout South Florida. In order to do that, we need to train and instruct our faculty, and we have a large simulation instructor program that we offer not just for faculty, but also fellows or residents, and even some students have taken that. Everything we've done throughout the history of the Gordon Center is grounded in assessment and outcomes research to provide evidence that what we do is effective, so that when we do adopt a new technology, it's based on best practices and evidence, and not just because it's the newest gadget out there. A lot of what we do is curriculum development, both internally and also supporting our colleagues throughout the University of Miami and more broadly. And then a key part of what we do to enable all this is in-house digital resource development and engineering development. My colleague, Dr. Ross Scalise, who is here today, is the director of our Educational Technology Development Division. And you'll see a lot of examples of what we do at the Gordon Center in that area. When people ask, how do you define simulation? Simulation is a unique connector between three main domains. Of course, it serves education and training. It helps us complement other forms of learning, whether it's in the classroom, online, in the clinical environment, to develop knowledge, skills, and teamwork. Unlike the clinical environment, which is the most rich place to learn about patient care, it provides a place where you can have safe, repeatable practice, where mistakes are forgiven, but you use those mistakes to inform through feedback improvement, and provides a way to ensure that our learners are competent. It's also a great test bed that if new technologies are developed with a hope that they may be applied in clinical practice, we can test them in a simulation laboratory to ensure that they're safe, to have a way for people who are going to be using this technology to get used to it. And finally, it serves the ultimate purpose of providing better and safer patient care. You'll see throughout the presentation that we have evidence now that training in the simulation environment in the right way leads to application of those skills in the clinical environment with improved patient outcomes. And it supports our goal of all academic health systems of continuous quality improvement, where you take the data from patient outcomes and process outcomes, and they get fed back into how you develop your education programs. So that is a context, a little bit of background about the Gordon Center and its history, both here at the University of Miami and its role of being a pioneer in simulation-based healthcare education. In the 1960s, as was mentioned, Michael Gordon was a cardiologist who came to the University of Miami with the idea of, much like in the aviation industry, of developing a mannequin that could simulate clinical cardiology conditions. He was a cardiologist. In the first inception of it, there were 3 different mannequins. Each one could only simulate a single disease. That was what the technology allowed. The oldest mannequin was showcased at the 1968 American Heart Association meeting in Miami Beach. A little side note fact is that when it was being developed in 1967, Times Person of the Year was Lyndon Johnson, and that's whose face they put on that mannequin. In the 1970s, Michael Gordon felt that there needed a facility, a proper facility, if he was going to develop this new technology. And at that time, in the late 1970s, he developed a 2-story, what was called Medical Training and Simulation Laboratory on the Miami campus. It still stands. It's adjacent to the Sylvester practice right near the Enchanted Forest. And so for close to 30 years, all the activities that Michael carried out were taking place in what was probably one of the first freestanding simulation centers in the world. In the 1980s, it was a decade where a lot of the studies were carried out to demonstrate the validity of simulation, and important studies that showed that skills learned on a simulator, in this case Harvey, could be translated to real patients. Because of that evidence, organizations such as the American College of Cardiology began to endorse or adopt simulation as a training modality to complement traditional training. The 1980s saw an expansion of the Gordon Center with the establishment of a division of pre-hospital and emergency training, which I mentioned is our largest training division, serving first responders throughout South Florida. That now includes members of the U.S. Army who rotate through the Gordon Center and practice at Ryder, and over the last decade, members of the White House Medical Unit. In the year 2000s, that decade, when we began the 21st century, we saw that what we do, if we wanted to scale it, we had to partner. And at that time, we began partnering with Laerdal Medical, who was the largest healthcare simulation company in the world, but pioneered simulation in resuscitation science. They were the founders and developers of the Resuscitation mannequin that we all use for CPR training. And then in 2000, with this 50-year development of simulation, there was wide-scale dissemination of an adoption of simulation throughout the state, both throughout the United States and globally. And then finally, in this decade, we've established key strategic partnerships to expand what we do and to have a greater reach. About 4 years ago, we began a partnership with the American Heart Association. They've adopted our acute stroke training programs in advanced stroke life support and essential stroke life support under direction of Dr. Yvette Mottola, where now those programs are the flagship training programs for the American Heart Association in acute stroke training. But to go back a little bit, have an appreciation of how rich the history is at the University of Miami. This is more than 50 years ago by a couple of months. This was actually an ad that occurred, a commercial that occurred in the Super Bowl, which that year happened to be taking place in Miami in the Orange Bowl between the Dallas Cowboys and Pittsburgh Steelers. And this commercial ran on the local market about Harvey.
45-year-old gentleman comes to the emergency room with acute, severe, crushing chest pain and the murmur of mitral regurgitation. Now, what does it do to?
Subaortic stenosis?
You're a student doctor. Your subject? Heart disease.
Myocardial infarction, a classic heart attack.
How do you find a heart patient to study? Well, one answer is Harvey, a mannequin with a heart. Using Harvey, students can learn the signs and symptoms for more kinds of heart disease than most doctors come across in a lifetime. Doctors at the University of Miami Medical School developed this experimental mannequin. The people at ITT designed its complex circuitry. Now others are being built with the same ITT circuitry to help train tomorrow's doctors.
1, 2, 3. 1, 2, 3.
When you consider that heart disease is the nation's #1 killer, you can see where Harvey has quite a future.
A few things about that commercial. That was Dr. Michael Gordon. Those were fourth-year medical students at the University of Miami. It's remarkable how different Super Bowl commercials have changed over the years and how prophetic it was, because since that time, more than 1,000 Harveys have been disseminated to about 60 countries throughout the world. I was only 7 when that commercial came out, and I wasn't yet involved in simulation. I can't say I remember it being on the television, although I was living in Miami at the time. But my introduction to simulation came about a decade later.
We should definitely keep that. You should definitely.
What you saw in that commercial was the mannequin itself, Harvey, but the original devices had a backdrop or a screen that projected information about the case, the patient history, bedside findings. It would guide the learner or the instructor through the case, and then would have images of the ECGs, the rhythm strips, the x-rays. But behind it was a giant mechanism that would contain hundreds of 35-millimeter slides and a carousel of 4-track audio tapes that, depending on which condition you chose, it would slide those trays around and insert them and then provide that lesson. Very remarkable. It's like a giant jukebox for medical education. But they knew that it was very impractical. I mean, it was impressive to look at, and certainly would look impressive in a museum. And so my introduction came in 1984, when my mother joined Michael Gordon as his executive director. And I had a little bit of an interest in medicine, but also computer. And so my role in 1984, I was in 10th grade, was to begin converting some of those 35-millimeter slides into a computer program. It predated the Mac, that I think it was an Apple IIc. And my role was to begin creating an interactive computer program, all text-based, so that learners would have access to this material at any time, or at least in a computer lab. Many didn't even have computers at home. I went off to college at Emory, and I came back to University of Miami. And during my second year, I injured my back, and I had back surgery, but then took an entire year to spend in Michael Gordon's research lab and work with the team to develop taking that original work I did in high school to develop a multimedia computer-assisted program to complement the Harvey simulator, where learners could have access to rich media materials at any time. Because a big limitation of coming to the simulation lab is that it was only open between 7 a.m. and 5 p.m. Really wasn't open in the evenings. And there was a lot of pre-work that learners could do before actually practicing their hands-on skills with the Harvey simulator. And so this addressed the time limitations both for learners and instructors. The work I did, this is a project in medical school. This is me sitting at the computer talking to some other students, getting their feedback on the system. And finally, my work extended when I was a resident, first at UAB and then coming back here at Jackson University, Miami. It was between 1998 and 1999, we felt that all the work that had been done at the University of Miami, we were ready to share with the rest of the world who were adopting simulation. And working with Michael Gordon, who's standing, and Dr. William McGahey, who's a cognitive psychologist, we wrote this commentary paper that was published in JAMA, really introducing the rest of the healthcare community about the possibilities and benefits of simulation. And the key themes of that commentary, which would really provide a roadmap for the next 25 years, was that if you're going to use simulation, it needs to be integrated throughout the entire curriculum. That way, the learners would have opportunity for deliberate practice so that they could acquire the expertise or mastery to move on to the next level. Now, deliberate practice was just becoming known at that time by someone named Anders Ericsson, who I'll come back to in a little bit. And then what correlates with the quality of performance or competence is the amount of ongoing deliberate practice that includes feedback so that learners can correct their errors and just repeat a practice over and over again. Now, what was missing from that equation, we had the technology, we had the educational purpose for it. We had the reason that simulation would be able to fulfill our mission of competency-based education was what was the clinical basis? Why? At the same time, that same year, a much more important publication came out by the Institute of Medicine, really highlighting the epidemic of medical errors both in the United States and throughout the world, where at that time estimating 44,000 to 98,000 people dying annually from medical errors. And I also put up our moniker, just again recognizing this as Patient Safety Awareness Week. The equivalent of that time was the statistics that would be the equivalent of a 747 jumbo jet crash filled with passengers crashing every day. Over the last 25 years, we recognize there's many domains and causes of medical errors and threats to patient safety. The human factors, communication breakdowns, system and process failures, medication treatment errors, diagnostic errors in environment and culture. A lot of this is familiar for those who are practicing or those who are licensed, because every 2 years we have to get updates or as part of our Florida medical requirements to be familiar with these major causes. And if you read anything or take any course about patient safety and medical errors, when you look and evaluate the root cause, typically they say it's a systems error. There was intentionally not to blame it on individuals because it felt it would foster a blame and shame culture rather than one that was really focused on identifying the cause of the error and then trying to implement remediation to improve it. And indeed, as a result of state mandates, including license requirements, the reporting of leapfrog scores, which looks at certain patient outcomes related to patient safety, and then local quality improvement initiatives that go into the accreditation of hospitals. They're an important part of our magnet status in our hospitals, are implementing solutions that address systems-based errors in healthcare system. But even as a result of all of those, as a result of all these, over the last several years, they've been able to document that these measures have led to reduced infections, improved survival, increased screening rates. But gaps still remain. And a lot of those gaps remain on the individual performance of people who are ready or not ready to perform in clinical practice. And so while there have been mandates at the system level, there has been no coordinated mandate related to ensuring that people who are training are ready for practice, or that those who are already in practice undergo continuous training to ensure that they have high level of skills. And so our argument is, or my argument has been failures of expertise development, not just system processes. So there are system responsibilities, but there are also individual responsibilities. And so that leads to a discussion about what is expertise. And the person I mentioned that had done the work on deliberate practice had coalesced and synthesized his work into a book called Peak. Peak looked at those at the very top of their game in any discipline. And an expert is those who are characterized by highly organized and refined mental representations. These are individuals who can think on a quantum level. They're not thinking step by step. They can think of multiple possibilities at one time. And by doing so, a lot of the routine tasks that they engage in day to day almost seems automatic. They're able to do it almost without thought. When there is a different situation or something that may occur rare, they have such a high level of expertise, they're able to adapt for novel cases or for extreme cases. What his work shows that expertise does not emerge from experience alone. Even when you become an experienced expert, you have to continue to engage in practice to maintain those skills. The practice is required not just to achieve mastery, but to maintain mastery. And so Anders Ericsson really initially didn't really focus on healthcare. He looked at outside fields. He studied the top musicians, people who are chess masters, and very elite athletes. And he looked to see where could he distill some common characteristics that were similar upon those who achieved really the highest level in each of their disciplines. In athletics, oftentimes I need Dr. Weiss here, it's commonly known that Michael Jordan, even at the peak of his success, would shoot 500 free throws every day. Larry Bird, at the peak of his success, would begin every practice shooting 500 jump shots. He would not end his practice sessions unless he made 99 consecutive free throws. So if he had 98 and he missed the next one, he would start all over again. It's well known, Steph Curry, about his rigorous practice sessions that enable him on the court to doing things we had never seen before by previous generations of players. And what Anders, his notion was that the amount of practice that's required deliberately is required not just to reach that level of mastery, but you must maintain it and be able to sustain it over and over again so that the skills do not wane. And so what are the steps related to deliberate practice and mastery of learning across all these disciplines? And then we'll talk more specifically about healthcare. The key first step is defining an explicit performance standard. What is the goal we want to reach? And make it a very high level. These aren't minimum competencies. These are very high level of threshold. Then a learner, you must do a baseline test to find out where the learner is. And then the difference between where they are and where they want to achieve is the gap. And that level of achievement is made known not only to the learner, to the faculty member, but to also the program. So it's no mystery. Learners go through deliberate practice, which is repetitive practice with coaching, guidance, formative feedback, focusing on the deficit, more practice, reassessment. And then at each point of time, once the learner reaches that threshold, that high level of achievement, they move to the next level in an ongoing manner. That lends itself very well if we apply it to simulation, the mastery learning to having safe, effective care. In a simulation environment, we can provide standardized exposure to high-risk events so that learners feel comfortable enough to make a mistake, not just so we encourage mistakes, but we can then provide feedback and we don't provide harm to the patients or any kind of psychological harm to the learners. It provides an environment for repetition over and over again until that high level is achieved. If there's any unsafe performance or concerns about how that learner or as an individual or a team is performing, we can intervene and provide additional feedback and opportunities for correction, and it provides an objective measure of competence. Now, why does this approach fit internal medicine? Well, internal medicine is filled with numerous different competencies which could be applied in a simulation mastery learning model. There are procedural skills such as central line bronchoscopy, diagnostic reasoning, complex events like managing mechanical ventilation, not just ongoing care, but acute management situations, treating a patient with sepsis or in a resuscitation scenario, and team-based care related to handoffs, where a lot of mistakes and errors can occur. And it's not just psychomotor skills or procedural skills or clinical reasoning. Several communication skills can be addressed in a simulation environment, including delivering bad news or having challenging discussions. Based on some of the work done at Northwestern, Dr. Schlieff has worked with colleagues in our division of nephrology and now in hematology oncology of developing training programs for our fellows and residents on having these challenging discussions. And I'm going to go through, the right is going to be a series of data that are typical of the results of a simulation-based mastery learning model. And what you see, the first bit of data, as you see that red line, it's maybe hard to make out, but the minimum passing standard in most of these studies are about an 87 to 90%. So it's a very high level benchmark to reach. And typically for all the pre-tests, because that is an important part of mastery learning, you can see what's a typical distribution of scores all the way from below 20% to a few almost reaching 87%, where the mean is about a 51.4%. So this is a typical distribution of learners going through any one of those different skills or competencies that you see on the left. And then if you, in a traditional training program, you follow these, in this case, residents over the course of a year, what you typically see at the end of the year is that there is some improvement. And these are learners not going through a simulation-based intensive training. This is just the typical experience they may go through, seeing patients, going through, attending grand rounds, morning report, where if you look, there's almost a 10% gain overall in competence. And statistically speaking, because the N is large enough, you would say, well, the increase is statistically significant. But clearly, it's insufficient if you're expecting all of these learners to reach the minimum passing standard. And so in all of these studies, this is typically what we see in the control group. In a mastery learning model, after the training on the first post-test, this is oftentimes the typical results. A significant improvement where the mean now is 86.1%. About half of the participants are at or above the minimum passing standard. About half are below. And traditionally, most programs would be satisfied with this. Say, okay, let's move on. In a mastery learning model, every learner has to reach that high level. And so those who haven't achieved it go through additional training until you have 100% of learners, whether it's students, residents, fellows, or practitioners, reaching that high level. And you may say, going back to this, well, that's fine. You've done a good job. They've learned these skills. They're tested in a simulation environment. What does it have to do with applying those in the clinical environment? And you're absolutely correct. When we started looking at this, said, well, if we're really going to make a difference related to this type of modality, we have to set up a pathway where we look at translational educational outcomes, much like the basic sciences and clinical sciences do in translational research. And so we define different thresholds where a T1 is performance in the simulation lab, T2 is applying those skills achieved in the simulation lab to the clinical environment. T3 is actually seeing a benefit of patient outcomes as a result of this translation of performance. And T4 are collateral outcomes. If you improve patient outcomes, could there be a reduction in cost? As an example. And so looking over the past, that was in 2012, about 12 years later, we began looking at some of the work that I was working on with our colleagues at Northwestern and other people were doing throughout the world. And we do indeed now see T3 outcomes, whereas a result of simulation training, often applied to a mastery learning model, we have evidence of reduced length of stay in the intensive care unit, reduced use of blood products, reduced incidence of pneumothorax and other complications, reduced radiation exposure, operative time, post-op applications, and improved workplace safety. This is very hard research to do to show these kind of translational outcomes through an educational intervention. I think one of the downsides of some of these T3 outcomes that we've been frustrated with is most of them are single institution with small numbers. We haven't, up until now, seen this scaled across an entire health system. And so we knew we had work to do, and we're trying to map out or plot out or strategize how we could get multiple centers working together to show much more broad-scale outcomes. Until last year, there was a study that was published in New England Journal of Medicine outside of the field of internal medicine, looking at birth-related mortality, in this case in Tanzania, addressing the global issue of 4.5 to 6 million deaths a year related to birth-related mortality of infant death and maternal death. And so this was work carried out over a decade, but the study occurred over a 3-year period, initially sponsored by the Laerdal Foundation, where they created what they called a bundle of care that included frequent high-dose simulation training, some innovative clinical tools that improve the monitoring capabilities of newborns and moms, continuous quality improvement where every single data encounter is captured and analyzed and implemented or fed back into the system, sometimes the next day, and supportive mentorship to support the people on the ground who are carrying out this training. The implementation was large scale, 3 years over in Tanzania, focused at the 30 most high burden hospitals in 5 regions, and looking at nearly 300,000 maternal baby pairs. Initially, they were focusing mainly on the neonatal mortality, so intrapartum stillborns or perinatal mortality, oftentimes from asphyxiation, with the second goal of looking later at maternal hemorrhage, which was the most common cause of death for the moms. In some of the pilot studies, they recognized that they had, in being so successful on saving the neonates, that they often saw because they were paired with moms, the mothers ended up dying. And so they're creating a population of orphans. And so for moral and ethical reasons, they decided not to wait on a second phase of looking and studying the effects of training people to address maternal hemorrhage and implemented it at the same time. And so over this 3-year period, it showed a very dramatic decrease, 40% reduction on newborn deaths as a result of this package. And while it was a secondary outcome, they were even more surprised. They demonstrated a 75% reduction in maternal deaths. And not just because of the simulation training, that was bundled with other features. And it just demonstrates that when there is a need, when done appropriately, it can have dramatic impact. Now that's in Tanzania. The last part of my presentation, we're really talking about some of the activities that are going on more locally here at the University of Miami. In looking at areas of deliberate practice, applied endoscopy, extended reality, patient-derived 3D modeling, and AI. The first one, after Dr. Spandi and I have been discussing for several years some of the work being done in other institutions, and asking the question, has this been applied in endoscopy, in upper endoscopy? And he said it really hasn't, even though you would think that a skill like endoscopy, whether it's upper or lower, would lend itself to a deliberate practice mastery learning model. We know in terms of the background that just relying on apprenticeship training can be limited in terms of slow progression of competence. You get variable learning outcomes, there's lack of standardization, and there are safety concerns, patient safety concerns, even though in most cases when a fellow is applying or practicing learning their endoscopic skills, often an attending or faculty member will step in if there's any concern. And so our goal was to determine if we could apply a well-established simulation-based mastery learning model to novice first and second week first-year GI fellows to achieve competence in upper endoscopy. We also had the opportunity of working with 4 other training programs throughout the United States, including University of California, San Francisco, Northwestern, University, Ohio State University, and University of Texas, MD Anderson. And so this was done this past summer with plans to repeat it again this coming summer. And so in advance, the fellows had opportunity to go online and learn about the basics, the details related around the procedure itself, the indications of upper endoscopy. They had to pass a test, and then the first week of their fellowship underwent rigorous training. The training was provided by an expert who was in San Francisco and done all virtually, because we also wanted to demonstrate whether we could create a training model where it wouldn't only rely on an in-person faculty member, because we often know that's a limitation because just the time constraints. And so through a series of virtual coaching, we had several different cameras set up where the learner could observe the coach. We also had a second instructor who could be remotely or in the room, observe the fellow undergoing the different steps and provide immediate feedback. The first stage didn't involve an endoscopy simulator that looked like an upper GI endoscopy. It was a basic task trainer where the fellows were just learning the fundamental steps of controlling the device, of the hand manipulation. Once they achieved mastery in that skill, they then moved on to the model that included the appropriate anatomy. And then similar to the studies I shared before, over the course of rigorous training during the week, several hours each day of learning these skills, all of the fellows at all of the programs reached a very high level of competence. We had a control group of second years who had gone through traditional apprenticeship training, and the majority of those did not reach that high level of competence. Although we're offered the training if they wanted to, because the resources were there. Our plan this next year is to repeat the study, to track these first-year fellows, and then to add a T2 evaluation where we evaluate their skills performing upper endoscopies on real patients. In the area of extended reality, as many of you know, is an umbrella term that incorporates augmented reality, which is the addition of digital data on physical data, often with a mobile device or a tablet. It can be also a headgear. Virtual reality, where the participant is in a fully immersive environment. Mixed reality, which is augmented reality, where the digital information is fully integrated within the physical environment, and then 360-degree video. And so oftentimes in using virtual reality, augmented reality, you have this technology and you try to figure out what you want to do with it. Well, again, discussion with Dr. Deshpande and Dr. Sussman and Dr. Ernsthoff, who was a fellow at that time, is can we identify an existing issue or challenge in the clinical environment and then see how we can apply this technology to address that? And one of the problems or challenges that was identified is that's well known within in colonoscopy is the missed lesions. Just the overall missed adenoma rate can be up to 26%, and 9% of these are advanced with posing the highest risk for a cancer. And the highest missed rates occur often in high-risk situations. So there's tremendous consequences of these missed lesions. And when looking at why they're missed, it's a combination of both technique and operator performance. And the suggestions for improving this moving forward is better visualization techniques, enhanced procedural methods, and greater thoroughness and inspection quality. So one of the needs we identified was there's a patient outcome need and the need to have better detect adenomas during endoscopy. The other had to do with the safety, not of the patients, but of the practitioners. And so this was provided by Dr. Sussman as a best case layout of an endoscopy room, where you have the primary screen number one, and you have other screens within the endoscopy suite where you may be looking at different patient information, whether it's a CAT scan or an ultrasound, maybe telemetry data. But you can see, even in this best case endoscopy suite, if you're carrying out a procedure, at any point in time, your attention is drawn to pick up data from another screen, you may miss, there's an opportunity to miss an adenoma or something, a suspicious lesion. But in reality, this is the actual endoscopy room. It's even more cramped. A lot of the screens and equipment was not laid out for optimal purposes. It's just, this is all the equipment that's involved in carrying out an endoscopy. You've got to kind of squeeze it in the room. So in addition to drawing your attention away from the field of view, there's a phenomenon that can happen when anytime you're in an area that's not designed for the most effective practice, that it can lead to repetitive use injuries. And in fact, when they've done studies looking at practicing endoscopists, that over 50% over a period of time will suffer a musculoskeletal injury, most often in the neck and on upper back. The graphic is just poking fun. This is the well-known Ascent of Man. The tall figure, second from the left, was the fellow Nate Ernstoff, just finishing his fellowship, ready to begin practice. The figure on his right was his father, also an endoscopist, after about 35 years of practice. So what was our goal? Our goal is, could we use this technology, integrate all those different sources of data information into a single field of view, and through voice activation, can the practitioner, rather than moving their head away from their focus, can they call in this different data to enhance their procedure? Now there are additional technologies where AI enhancement can be incorporated into the endoscopy system, such as GI Genie and others, where if the video, if the AI evaluating the video images detects that the endoscope has moved past what may be a suspicious image, the endoscopist could be alerted through noise, through a vibration. And so the combination of these technologies merging together, the hope is that it will lead to more effective endoscopic procedures and better outcomes. We've applied for a provisional patent because we think this technology has application not only during endoscopy, but almost any procedure in which there is a camera involved, or digital view, and multiple sources of information. This could also be incorporated with AI-assisted dictation and encounter notes to be able to incorporate all of this information together into a single system. And another area of simulation is related to three-dimensional modeling, and how can we use patient data to create very specific models that can then be used for training or rehearsal. And this is a project I'm proud to be working with Dr. Cody Atkinson, who's in the Division of Pulmonary Medicine, Critical Care, and Sleep Medicine. Dr. Atkinson is a junior member of our Academy of Medical Education Scholars, and his proposal was that he is one of the very few in South Florida practitioners carrying out a very new technique of robotic bronchoscopy, where using this procedure, the practitioner is able to go much further into the lung periphery to biopsy suspicious lesions. But it's a totally different skill set than traditional bronchoscopy, which is all visual based with the camera, much like GI endoscopy, where you're using other types of data, such as CAT scan-derived pathways, two-dimensional fluoroscopy, to kind of guide the tip. And the challenge is not so much with the navigation, because a lot of the system will kind of guide you because it has the patient's CAT scan. It's once you get to the suspicious lesion, the manipulation of the instrument to actually get a safe biopsy. Dr. Atkinson had the idea that it would be great to develop a simulation program around this, but at the current time, because this is so novel, there are no proper simulators. Most of the simulators are related to traditional bronchoscopy. And so we thought, how can we leverage some of the technology, the 3D printing technology we have that we use with Harvey, and come up with a robotic bronchoscopy lung model that can then be used in a simulation environment that would allow navigation not to the second or third branch, but up to the sixth to eighth generation branch that would also allow a 3.5 millimeter catheter to provide surrounding realistic parenchymal deformation during articulation, because that's what occurs in the real environment, fluoroscopy, visible biopsy, capable of peripheral lesions. And so our idea is to take CAT scan data, 3D print a bronchial tree, use formable silicone around that 3D printed bronchoscopy, have that 3D printed model be able to be dissolvable. So what you have remaining is a flexible bronchial tree that then it would allow navigation of the robotic device into these very peripheral areas. This is the kind of very early stages, but it's just a demonstration for those that are here in the auditorium or listening. If you have ideas about developing some of these tools, more specifically, very patient-specific training tools and training models, that the Gordon Center is a resource if you're interested in collaborating in this type of project. In the last area, not surprising, is artificial intelligence. One of the challenges of now using simulation so much throughout training is that we're collecting large amounts of data. So much data that we're not able to process it consistently enough or in a timely manner to be able to give it back to learners so they can use this data to improve their performance. In addition, learners are both at the undergraduate, residency level, and continuing education train in many different areas or practice in many different areas. And how do you make sense of performance data in the hospital and clinic and the simulation laboratory at the same time of wanting to provide more precision training and make it more adaptable to the learner's needs as opposed to a one-size-fits-all? And so in a project working with Dr. Shafazan, who's the director of the Office of AI with the Department of Medical Education, Dr. Obeso, who directs our clinical skills training program, Dr. Bland, who oversees phase 2 of the next gen curriculum, and Ms. Samantha Sims, who directs our standardized patient program, is how can we use artificial intelligence to enhance clinical performance assessment, not just in the simulation center, but also the clinical environment. And so we're currently working on a project where we're training an AI model, feeding it several years of previous performance data of de-identified learners, of using the rubrics, the checklist, the rating scales, the scripts, feeding in all of past faculty ratings of those performance data. We also have several thousand recordings of learner performance in the simulation center that have been audio-video recorded. We're going to pull the audio transcripts initially and enter that into the system. The video will take a little bit more time because it requires much more processing power. And the AI engine, the application will learn. It'll review the audio transcripts and be able to compare the raw data with the evaluation data from both the faculty and the standardized patients to be able to identify any differences. And now we've actually found differences early on in that while we've relied on the faculty ratings as the gold standard, often there's inconsistencies between raters on a single individual, or even among that faculty member who may give a rating, a 4 or 5 on a rating, but then indicate on a checklist several things that were missed. And so having this application will be able to, in real time, identify inconsistencies so that when we do provide feedback to learners, it's reliable, consistent, and it's something that they can trust. You can also look at it to detect any hidden areas of bias, and also just ensure that we're having a reliable system, that the data we're collecting and can be used effectively for learners, but also for the overall program. And putting this all together allow us to generate reports detailing any kind of grade discrepancy, early remediation alerts, so that if a learner isn't reaching a high standard, The faculty member can be alerted, and we can bring the learners back in a much more timely manner to remediate and to be reassessed. And it'll allow longitudinal tracking of competencies over time. Right now, it's a very labor-intensive process to do this in an effective way. There's one program at the University of Texas Southwestern who has implemented a system similar. And just in the first year, they've been able to reduce the amount of time, the human time it takes to review a lot of these ratings and evaluations by 90%. So there's a lot of promise in this area. We're also looking to incorporate some of the AI technologies that's used in the clinical practice, like Suki, and to be able to complement these applications with what the learners are going to be using in the actual clinical environment. So moving forward, feel that the model of simulation-based mastery learning, increasingly augmented with extended reality and AI, will lead to better trained physicians and safer patients. And just ask those of you here that are listening, who are watching online, to think about identifying one high-risk domain in your program. It could be an area of diagnostic reasoning, procedural communication, teamwork skills, and think about designing a mastery learning pathway. All of us are working at the Gordon Center and the broader community at the Miller School in medical education welcome the opportunity for collaboration. And I hope that this presentation is just a first step for ongoing possibilities and opportunities for collaborate. I'll end that with just thanking you again, Dr. Weiss, Dr. Deshpande, for the opportunity for this presentation. And I'd like to acknowledge all of our team at the Gordon Center, whose dedication and commitment every day make it possible for us to fulfill our mission of saving lives. Thank you.
Thank you, Barry, for being here today and being really an icon in the field of simulation medicine. We're grateful for all your contributions and what you bring to the University of Miami. Perhaps I can begin by asking a question. Given the heterogeneity of learners that we have in who gets accepted to medical school, it's very different than what it was when you and I applied, and who goes into medicine today is very different. And so, nevertheless, despite that heterogeneity, we want everybody to be competent, right? And so that's the goal, and not at the 75th percentile. I don't want my polyp missed. I want it 100% of the time caught, right? And so what have we learned about the way in which the brain processes information differently from one individual to the next? In other words, not every simulation model is right for every individual. And so there needs to be a personalized approach that's taken. For example, I can't find my way to get to Doral, let alone figure out how to use a colonoscope to manipulate left and right. So I definitely didn't go into GI. So, but nevertheless, have we learned anything more about how we can better personalize the training that we give our learners based on the way in which they learn differently?
Great question. I think up until now, people have done work. There are some groups in Canada who have evaluated the learning preferences, strengths, and challenges of learners, and be able to predict whether or not they're more likely to go into surgery or having some procedure based on their spatial abilities. And there are some individuals who are just more adept of understanding three-dimensional space, and have then customized some of their anatomy programs and training programs based on the learner's level. But it's very labor intensive. I think the promise with artificial intelligence is that early on, we'll be able to detect the learning preferences of individuals and then customize the learning opportunities that are best suited to their learning style. Up until now, it's been very, very challenging, very labor intensive, and done at a very small scale. I think I'm pretty sure that with using AI appropriately, we'll be able to do this at a much larger scale.
Thank you. Dr. Brown.
Thanks, Barry. Great grand rounds. I have sort of a similar question, but it's more about the faculty feedback for the project that you're working on with Dr. Shafazan et al. Since you found areas of bias, are those sort of particular faculty or general? And what's sort of the next step? How do you fix the faculty component, or is the goal to say AI is going to actually grade all of these?
Right. So great question. So the bias comes in many different ways. Sometimes it's a temporal bias where we'll have faculty evaluate several learners in a row, and based on the performance of the previous couple of learners, they're more biased to judge the next learner one way or another, as opposed to an independent. Some of it are biases related to the specialty of the faculty member. And so what we can do early on is not to say this faculty member was wrong, it's just to identify and make it aware of it. Some of the biases are related to standardized patients who are reluctant to give a poor final grade to a student in which they trained during the formative assessment. And so it would be much more difficult to identify that manually. We're now able to detect those patterns and be able to intervene early on. It's very early work, but we're very excited about it. And Dr. Bland is particularly looking at mitigation of that bias and across the faculty. One more question? Okay.
Hi, thanks for the talk. I'm Daniel. I'm an internal medicine intern. I was kind of curious in one of the research that you were presenting on in terms of central line simulations as internal medicine residency, like what sort of procedures do we have access to at the Gordon Center for simulation?
A great question. I think we work very closely with, and I also acknowledge, we have two other simulation centers at the University of Miami, both the Center for Patient Safety and also the MISTI, the Surgical Simulation Center that's at Rosenstiel. We have a wide range of different simulation and task trainers, including central line, lumbar puncture, thoracentesis. And so I would say the recommendation is to reach out to us. You can reach out to me directly, and we'll kind of give you a tour, kind of give you a menu of the different type of devices that are available. Increasingly, both at medical student and residency level, there's an increasing interest in point-of-care ultrasound. And so we have a very large growing POCUS program.
I want to thank Dr. Issenberg, thank all of you who are here in the audience and 90+ individuals on Zoom. I want to remind everybody to check the chat or the QR code as you leave in order to obtain MEC and or MOC from the Department of Continuing Education, Dr. Issenberg, who is running that. And wish you all a great day. Take care of yourselves and each other, and we'll see you next week. Thank you.